Thank you, Karsten. Oh, I'm next. So we're actually now moving away from stress PC. Okay. Moving away from MR imaging, and actually I'm in a lab where we do have MR imaging, but we're also using PET imaging. And I'll frame the presentation in terms of a clinical problem we've had. So we're working with neurologists who are seeing elderly subjects, and so the subjects that were selected were showing mild cognitive impairments. So they start losing their memory, and they kind of worried about developing a Alzheimer's disease. So, and actually they were followed for a few years, and some of the subjects actually turned to be turn into and develop the Alzheimer's disease, but other subjects just kept their mild cognitive impairment, and their ability didn't worse over time. And the question the neurologist had was, could we actually predict which subjects that they were seeing would turn as AD, or which ones among their MCI patients are actually early AD, and it's just that they haven't figured yet that they will develop the disease. So we were trying to predict that. So the kind of data we had, I know it's a very limited population, but it's working with patients. They are kind of difficult to acquire. They were visiting the clinic. So they were all diagnosed with MCI, and they were monitored for 6 years at the row. And in the end, we split the data into two groups. That is the AD converters and the 20 subjects that would be stable MCI. So you see on the top right, the graph is actually the number of conversion to AD we observed over time. So the horizontal axis is time expressed in years. And what we noticed is that most, if not all, the conversions happened within 3 years. So we used that to sort of label our subjects. And the data at hand, so they underwent a FDG, so-called FDG PET at their first visit at the lab. So they were diagnosed with MCI, and then we've got this FDG PET. And then at the time, they also had this, of course, the age, the MMSE score, and another 5 neuropsychological scores. Afterwards, we didn't image them anymore, but they were seen like every 6 months to 1 year, at least. Well, with elderly subjects, we had also a few dropouts just because they died. And we didn't image them. And then the evaluation in terms of converting to AD is based solely on their psychological testing. So for those who are not familiar with PET imaging, it's not dead. It was big in the 80s, but it's coming back with some interesting radio tracers. But this 18F-FDG, it's a classic. It's a glucose analog. So what you do is you inject, you create a molecule that looks like glucose, except that there is a 815 fluor atoms that will allow you to trace this glucose molecule in the head of your, well, in the body of your subject. And since this is a modified glucose molecule, it will fixate in the brain. And because the F18 has a decay of about 110 minutes half-life, you've got plenty of time to do the scanning. So in the end, every FDG map looks like the colorful image you have here at the bottom right. And it's pretty much the resting state energy metabolism. So it's a quantitative, well, it can be made quantitative measure of the glucose intake of the brain. And a hallmark of Alzheimer's disease are areas with hypometabolisms. But just keep in mind that when they scan, they all presenting the same symptoms. They all MCI, and so they don't have these clear hypometabolic areas visible in their images. When you're playing with PET images, so a few points in terms of the imaging technique itself, it depends how data were acquired. Ideally, you would have really a quantitative measure, so you would have really the glucose consumption per minute per volume. And there, you don't have to worry about the scaling, because whatever number you have in each voxel is an actual measure. More generally, you don't have this quantitative value, and you get just an estimate of the distribution. But depending on how much radio tracer was injected, or the time between the moment it was injected and the scanning, it usually takes like 20 minutes injection, 20 minutes and 30 minutes scanning, but sometimes it's longer with patients, problems arise. Basically, you don't know exactly what is the scaling of your image. And it's not uncommon to rescale your images using the mean signal from the whole brain. But this has problems with patients where you have large, extended hypometabolic areas. And so it's usually preferable to use as a reference region, a region that is not affected by the disease. So in this case, we knew that we could use the cerebellum as the reference volume, so we would be rescaling images using this signal coming from the cerebellum. Another problem you have with PET, because of the scanning technique itself, you have quite low spatial resolutions. I mean, low by the standards of what we have nowadays with structural MRI. And there are issues with partial volume effects. And there are ways of correcting that, but that's only possible if you have a good structural image, which is not, well, in our case, I must say, we didn't have those structural images for all the subjects, so we couldn't use this correction for partial volume effect. And an even more pressing issue is this normalization. Because we have all the subjects, we need to bring them into a common space to do our pattern recognitions in terms of voxels that are representing the same area of the brain. Once more, if you have the structural image, then it's much easier to work with the structural MRI because of the spatial resolution. One caveat, though, is most of the templates or tissue probability maps that are floating around, or at least that are distributed with packages like SPM and FSL, are were built from young, healthy subjects. So it's not actually matching the data we have at hand. Nowadays, you can find some tissue probability maps for elderly subjects, but I mean, you need to be a bit more careful with that. And in our case, we didn't have the structural MRI, so we had to rely on PET normalization on its own. And there it's complicated because, in fact, you need to create a template, and that PET template will depend, obviously, on the radio tracer you're using. So if you've got a water PET, it's not the same as an FDG PET. You have the problem with the population, so elderly subjects will have, again, a slightly different brain structure and hence a different distribution of their radio tracer. Then there is the issue of scanner and reconstruction algorithms. So depending on where you acquired your data, and that happens when you're collecting data from different centers, the images you will obtain in the end could be vastly different in terms of smoothness and actual resolution. And depending on the algorithm, you may or may not have some types of artifacts in your images. So all in all, dealing with PET images requires quite specific spatial preprocessing, and if possible, try to have also a structural image along that can really help, on top of also providing information about gray matter density if you do the segmentation. So the technical issues I want to address regarding pattern recognition, there are two things that I want to cover, and we did that with a former postdoc in the lab using those clinical data, is the combination of imaging data and clinical scores and the dimension reduction of imaging data. So the reasoning is the doctors base their diagnostic on observing the images, but they're also using all their clinical scores, neuropsychological scores they're using. And if we stick with mostly what was presented so far, everyone is just using the images. And it's a bit of a shame not to use the other information that is there, but it's not in the imaging format. So this feature combination is clearly something we need to work on. And also the idea here was that our images, because of the nature of PET images and the distributed signal we have, we wanted to extract features, but not in terms of localizing, picking up one region or a bunch of voxels, but more using patterns. And that was this idea of decomposing our images into patterns, and then you've got, for each pattern, you've got a score. So you go from thousands of voxels to a few tenths patterns per for your image. So you reducing the feature space. I'll go through these. So dimensionality reduction. We stick to quite standard approaches, and we tried a few of them. And the most obvious would be was using principal component analysis. So the idea is, you've got here on the left is your original image. Well, I mean, we've got a bunch of them, and with a bunch, sorry, with a bunch of those images, we try to decompose those by creating orthogonal patterns, capturing. So these components, these patterns, capture most of the variance across all your data. And for each pattern, so once you have one image, you can express that single image as a linear combination of those patterns. So, and each pattern gets a score. So one image is then turned into a series of those numbers. In mathematical terms, it means that each score is the projection of your image onto that specific pattern. So it's a nice and efficient way of summarizing the images. And of course, you do that with your data and show how it's applied. The other way of doing things, another way of doing it that is similar but also different, if it was the same, it wouldn't be fun, is to use partial least square, where you there also decomposing your image into orthogonal patterns, but you want to make sure that you have a maximum correlation between the part that is associated with the image and the part that is associated with the labels. And again, the idea is to, instead of having thousands of voxels, you want to limit yourself to a limited number of components. And this way you would, again, be summarizing your thousands of voxel values by just a few numbers. And finally, we also played a little bit with the idea of ICA. It's not an extension of PCA. It's based on a criteria of statistical independence between your components. So it's one of those methods to decompose. It's a blind separation of the sources. So here the matrix X would be my images, all my images stacked together. A is the mixing matrix, and S is the sources. So I would try to find the matrix A and then invert that to find this W, such that each of my components is statistically independent from the others. So it's not the same as being orthogonal. And with that, we again have a way of projecting the data on these independent components, and we can choose well, we can retain just a few of those components, and the weight of each component gives us a summary of our image. So the the assumption here is that we want to summarize the whole image by a few numbers. So assuming that the information is really spread or throughout the brain. So here we sort of cutting ourselves from any localization of the part of the brain that is contributing most, because we explicitly make the assumption that this is it's distributed because we're working with only spatial components that covering the whole image. And obviously what we want to do is keep as few components as possible. For PCA you can use percentage of explained variance, and with PLS and ICA you can use a Fisher discriminant ratio. So the fewer the components, the fewer the scores, the larger the dimensionality reduction. So now how can you use that? Well, if we were using a leave one out cross-validation, with the limitation of that, we split, and then you can do your dimensionality reduction on your training set. You end up with a bunch of components and features. Then you do your training on the features. And because you have fewer numbers, we're hoping that we get some more stable classification. And then once we've done the estimations of the decomposition and the classification, we can then take the left out sample, project it, extract its features, and apply the classification so we get the class prediction. So it's pretty much the standard approach. The only thing that we've included here is this dimensionality reduction in between the data and the training of the machine. When it comes to feature combination, so the classical approach, if you only have images and no clinical score, it would be take your data here, include or not dimensionality reduction, do the classification, and do the class prediction. But we tried different ways of combining the two sets of information. So you've got on one hand the image data and then the psychological scores. So we call that early integration. So we just stacked up the scaled psychological scores with the image features. So the projection of our images, because we have usually reduced the size of our images, and then the weight of each component are like scores by themselves. So we just put them together into a single feature vector per subject, and then this is like a mixed feature, and then you can apply classification directly on that and then get your class prediction. That was sort of straightforward. You reduce your data, stack the other scores. The only thing you have to worry about is the feature scaling. I mean, but that's in general. I mean, psychological scores, they go maybe between 0 and 10, but other scores would go between 0 and 100. So another one would be between 0 and 33. You need to bring that to something that is similar. Similar scale. So you would just bring them all the values between, rescale all the scores. So that's early integration. Another way of combining things would be to also do this image reduction, or you can actually omit it here, and then you create a kernel per sets of information. So here we've got just one image and the psychological scores, so you get two kernels, but you could imagine that you would have multiple image modalities, and then that's back to this multi-kernel training, and you can do your classification. you need a multi-kernel algorithms. No, it's available. At the time we worked on that, it wasn't that easy, but now it's totally doable. And then the late integration joins what Jonas was mentioning early on this morning, is you do your training and classification on each modality, on the images and the psychological scores independently, and then you combine the outputs of the classification. So you get a prediction from one set of data, and well, one type of data, and a prediction from the other type of data, and then you combine them, whatever the way. The easiest would be voting, but then you could also include other ways of combining them in terms of confidence you have in one prediction more than the other. So all in all, that's the different schemes that we were considering, just images, early, intermediate, and late. So I'll quickly go to, the results from what we tested with this, I know quite limited data, but it's still interesting, is that if you're only playing with images, actually for this type of data, doing the dimensionality reduction did help the prediction. So PLS was doing better than PCA, than ICA, than no reduction. When we we used this when we used the scores, we had the psychological scores and the MMSE value, and then the age, and we compared that with just using the neuropsychological scores alone. And as could be expected, the more information you put in, the better the prediction, especially age, because all the subjects that were in AD were on average slightly older, so age was clearly a feature. So pretty much in advance, you know that if the guy is older, you can expect that he's turning AD. He's more likely to turn AD than a younger subject. And when we compared the different procedures of integrating, mixing up the data, what we found is that the intermediate and late were giving us the similar results, and that was performing better than early integration. And that's quite understandable in the sense that when we mixing the scores from the images and the neuropsychological scores, we kind of mixing things and that don't have the same origin, while if we do the intermediate or the late, we're not going through those scores. We're putting them together, but at a later stage in terms of kernel, so we were not mixing apples and oranges in a way. So conclusion and comments. Depending on the data you have, image dimensionality reduction could be an option, and maybe for small sample sets that would be that can be an option. It's also a way of denoising your data. So if your data are noisy and pet data are noisy, it was a good way of keeping the components that contain signal and throw out some bits that will probably noise. Feature combination, that's something when we're playing with clinical data and comparing groups of patients and with different diseases, or here in this case patients that would have a different outcome in the future. Clinical, well, all scores would be interesting, maybe blood samples or something, values you can extract but that are not images. It's worth investing some time in collecting them and trying to combine that information for your classification. As that was said previously, there is no one-size-fits-all solution. So depending on the problem you have at hand, your assumptions on the whole things combine or how things are distributed in the brain of your subjects, you should pick the most appropriate solution for your problem. And something that we were not using, we just stuck with the standard SVM. When you're dealing with clinical applications, it would probably be more interesting to use machines that output a probabilistic classification. So SVM gives you a hard classification, but other algorithms like Gaussian processes would output a probability of being in one category or the other, and sometimes also a confidence measure. I mean, having a probability of converting to AD of 60% doesn't bring in the same information or the same impact as having a probability of 95%. So from the medical point of view, probabilistic classification are something that should be considered. And I've put the references of most of the papers that explain the methods I've shown you. And I want to thank my collaborator from the team back home. Thank you. No questions? If you feel like me, I understand that you don't want to ask questions. Oh, yes, we have some.
I may have missed your last sentences, but my question is, what did the neurologist gain from the PET after all this transformation and inclusion in the other data set?
What they gained, it was, here the idea was, from a practical point of view, if they could predict that the subject they were seeing would develop Alzheimer, then for the family and everything, it was easier to plan the future, and they could be prepared. So that's just for the care of the patient. Something that could also be important is in pharmaceutical applications, where when you have to select subjects to test, say, new medication to slow down maybe the development of Alzheimer's disease, if you get someone and you know he has a very high probability of developing Alzheimer's disease within 3 years, then it would be a very good candidate to test that new drug. And then you if he doesn't switch to AD within 3 years, you could, and you do that on many subjects, then you could say, yeah, my drug is probably doing something. While here, if you just pick subjects with just that information at time 0, you don't know, because half of them will turn, and you will need to have a much bigger population to figure out if your drug is actually active in terms of slowing down the development of Alzheimer's disease. So that kind of things could help in terms of which subjects you want to follow up or have a more careful look after.
No, that is perfectly understandable. The question is, if you take the brain PET alone,
yes,
what difference did it make to the neurologist if the nuclear medicine person reads the PET versus the PET is now included in your data set?
If you use only the scores, it wasn't, so combining led to a better prediction. So if you use the image alone, you get, I can't remember the numbers, but some prediction accuracy. If you use just the scores, that would be much easier to collect the data. You get some level of accuracy. If you combine both, you get better prediction.
Yeah, I was trying to, the magnitude, how much improvement is there as compared to just reading the PET?
It went from something in 60-70% beyond, and I think we reached like 90% accuracy.
Right.
So it wasn't, well, it's also a quite limited data set with only 46 subjects, but we're working on that.
Thank you.